Greetings. First of all, I want to thank Raj for this kind invitation. And unfortunately, I'm unable to be I'm unable to make it there due to some health issues. And so I decided to record this presentation. And actually, I'm a little bit disappointed because I was looking forward to learning from all the experts there and being a great fan of Professor Vido. I was very much looking forward to listening to his presentation. Anyhow, so I want to talk about EMR versus ESD. EMR is better. I'm not sure whether we should say EMR is better or ESD is better. We should say what is better for the patient. That's what we should do. But EMR is better for a lot of patients, and but not necessarily for all patients. That's one big message I want you all to keep in mind. These are my disclosures, and I'm going to talk about these different topics and cover this debate. So, a couple of years ago, we presented 4 images to gastroenterologists who attended the Texas Society for Gastroenterology at our annual meeting, and we asked them about their practice, and we asked them to select what they would do for each of these images, and all 4 are cecal lesions. And when you look at the data, only a small proportion decided that they would take care of all the patients with endoscopic resection. Almost close to half of them conveyed that they would refer the lesions, at least one of the lesions, to surgery. So what it shows us is that even lesions of this size are being sent to surgery in Texas. So let's talk about surgery, and let me review the literature on this topic. There are a couple of excellent articles that came out recently about surgery for polyps, colon polyps in the United States, looking at over 1.2 million surgeries over a span of 15 years. As you can see, a quarter of these colon surgeries are performed for benign colon polyps. And it's also important to keep in mind that 25% of patients who undergo surgery, colon surgery, have morbidity, and about close to 1 in 100 have a risk of dying from that procedure. So, colon surgery, although we have certainly evolved over a period of time, still carries a morbidity and mortality. This information is probably true across Atlantic. In a large study starting from 2000 onwards, compiling 26 studies over 100 colon surgeries. Again, the same thing. 25% of the surgeries were performed for colon polyps, and mortality is still about 0.7%. So it is not free from mortality. So coming back to the survey that we performed at the annual meeting of Texas Society for Gastroenterology, what happened to these patients? And I want to share with you that all 4 patients, large flat lesions, granular, non-granular, type of lesions, underwent endoscopic mucosal resection with no complications, and surgery was avoided. There was no recurrence. So let's take a minute to talk about surgery versus endoscopy for colon polyp resection, that is benign colon polyp resection. Surgery is costlier. This is data based on 2010 and is associated with a longer hospital stay per patient. So, having seen this data, we need to ask ourselves what is needed for EMR. EMR is a very simple technique, needs very little, just a few dollars, maybe $10, $15 for an injection needle, and maybe another $10, $15 for a snare. Only 2 devices for resection. Maybe you need other devices to cut down the risk of complications, but just for resection, within $30 to $40, you could do resection in terms of the equipment costs. When you look at which lesions are amenable for endoscopic mucosal resection, we should look at and understand the colon wall and its pathology. You should be able to resect lesions that are limited to the mucosa, that is, whether they have intramucosal cancer or not. You should be able to resect them with endoscopic mucosal resection as long as you perform en bloc resection. You could also consider for early cancer where the cancer is invaded to the upper 1/3 of the submucosa. As long as you are able to do en bloc resection, you should be fine. But when the lesion goes deeper, then the chances of lymph node invasion are there, so they will require surgery. Those patients do not benefit from endoscopic mucosal resection. So to summarize, adenomas with or without high-grade dysplasia, intramucosal cancer, well-differentiated cancer with submucosal invasion depth of less than 1,000 micrometers, well-differentiated with no lymphovascular invasion, could be taken care by either EMR or ESD. EMR when it is done as an en bloc resection for those with superficial invasion into the submucosa. So let's talk about the difference between EMR versus ESD. ESD, because it removes the whole lesion as an en bloc, has a higher curability with low recurrence. Safety-wise, ESD tend to have a higher perforation. EMR is much more safe, and ESD takes much longer. So these things need to be kept in mind. Say, for example, you end up taking 2 to 3 hours to resect a lesion that could be resected in half an hour with EMR. So 2 to 3 hours for ESD versus half an hour for EMR or an hour for EMR. You have to keep in mind that by having a good outcome with EMR, as long as you can have a good outcome with a shorter interval, you will be able to take care of a lot more patients efficiently without necessarily making them wait for your services. So that is something to keep in mind. But when it comes to a patient that needs ESD, you should go for ESD. So although this is the data that shows that there is a higher recurrence rate, I would like to show you our own data so that it helps you appreciate that we are not that high, and we can actually come down to 3% actually in terms of recurrence rate. So how to do a good endoscopic mucosal resection? I would like to share with you our own protocol. I joined MD Anderson Cancer Center in 2009. I followed the same protocol. This is what we do. Our business office sends patients a data sheet with images to explain the procedure, and we include YouTube links and encourage people to watch videos. and most of them do watch videos before they come to the clinic. And in the clinic, after assessing their general health, I try to show them a lesion in a particular location where they have the polyp, and go through the procedure, showing the video and explaining the risk, benefits, and alternatives, so that by the end of the procedure, they are well versed with what is to be expected. When I come to the endoscopy unit for the procedure, I actually sit down and talk with my team, showing them the lesion and what the game plan is. It's important for your team to know what to expect, so that they're not rushing in and out of the room trying to grab different pieces of equipment. From the technique point of view, one should focus on a good colonoscopy insertion technique as you learn colonoscopy, and be able to reach the cecum at 60 to 70 centimeters. That is critical. When you can do that, you should be able to do EMR very well, because you can actually bring a lesion to 6 o'clock, irrespective of where it is, by having a good scope tip control. So once you see a lesion, you should ask 3 questions. You should scan the surface for cancer. You should look at the edge to see whether there is a skirt lesion, and if you don't identify that, there is a high risk of recurrence. And if you're doing traditional EMR, you want to keep the lesion in a non-dependent position. Not dependent, but non-dependent, so that if you cut and the lesion bleeds, the blood will flow away. If the lesion is dependent and you cut, you will not find the bleeding vessel because the blood keeps pooling up there. So after seeing this, this is the protocol that we have followed for the last 10 years. We published this in GI endoscopy, and we followed the same protocol. We did EMR with a cap-fitted scope, and after EMR, I took maybe 5 to 6 photos of the edge and the base to make sure there is no residual polyp, and then routinely cauterized the edge, starting in 2009 with APC set at 0.8 liters of flow and 35 watts, and then routinely closed all the defects with clips. The number of times we did not close defects with clips is pretty small. And then we followed them closely with emails and phone calls to document any complications and recurrence. In the initial report of 203 patients, including everybody that came for EMR, we were able to avoid surgery in 75% of those patients. None of the patients who underwent EMR required emergency surgery. The bleeding rate was about 3 to 4%. We had no perforation, and the recurrence rate was also very low, 3 to 4%. So low complication rate, low bleeding rate, and low recurrence rate. And I'm happy to see that recently there is a study from Australia, from Michael Burke's group, where he used a much simpler technique of snare tip soft coagulation, 80 watts and effect 4, to cut down the risk of recurrence. And this is something you should get into your practice. So if you have heard my other lecture, when I set up my OB machine, I use endocut Q on the left side and soft coagulation on the right side instead of forced coagulation. And the soft coagulation helps you to coagulate blood vessels and also helps you to cauterize the edge of the resection to cut down recurrence. Coming to clip closure, I believed that clips and clip closure would be beneficial starting very early in 2009. I'm delighted to see 2 great papers, one from Heiko Pohl and another one from Spain, showing that the delayed bleeding rate can be cut down from 9 to 10% to 3 to 4% with clip closure. In addition, there is a cost saving, as shown by another paper of about between $300 to $400 by applying the clips. It's also important to acknowledge the great work of Michael Berg that helped us understand the depth of resection, identifying different levels of resection. And when you cause damage to the muscle, you should close the defect to cut down the risk of any delayed perforation. So here I have actually summarized all the papers that have shown that published the recurrence rate. You can see the recurrence rate has been anywhere between 10 to 20%. At the bottom, you see our own work where we not only resected but examined carefully to make sure that there is no macroscopic disease, and then ablated the edge to get rid of any microscopic foci. And by doing that, we have shown that in large polyps, over nearly 246 patients, the recurrence rate has been very low, and these recurrences could be managed by subsequent endoscopy. I would like to comment about some of the limitations of endoscopic mucosal resection based on our own experience. As you can see here, in the initial study, we have noticed that a quarter of the patients were not able to avoid surgery. Some of them because they had submucosal cancer when we first saw them, or the lesions were tethered, or lesions were too large for an EMR, because my experience has evolved over a period of time, and some where the lesion was very difficult to access and not able to bring it down to the 6 o'clock, and in a few from unrecognized polyposis. When you cannot resect by EMR, you should make that decision up front and then take the help of others like ESD expert to resect those lesions. So recently I had two patients where one with a large rectal lesion that I felt that I will not be able to resect safely, and not able to resect completely. So I decided to defer, and one of my colleagues, Muhammad Atman, did the resection. And another patient where there was too much of movement of the colon for a safe endoscopic mucosal resection, my colleague Philip G., who does ESD, was able to tunnel, and the tunnel actually kept his scope stable and able to resect. So it's not about what technique to do. We should keep in mind what is the best way to help our patients, and that's the key. And it's also important for you all to read this book, Better by Atul Gawande, where he talks about how you can constantly improve the quality of care. At the end of the day, the patient would ask and the family would ask few things. Did they have a prompt service? Did they have a curative resection? Was it cost effective and affordable? And were they able to get out without complications? Any management plan should consider all these different aspects when managing a patient. So I would like to present this slide. That is, when you see a large polyp, make sure you provide a detailed endoscopy report talking about the morphology of the lesion, longitudinal and circumferential extent of the lesion, detailed photo documentation with lots of photos from long shots, medium shots, and close-up shots, and also comment on difficulty of accessing the lesion. And finally, if you have a cecal lesion, comment on whether the polyp goes into the appendix or not. And when you do the examination, consider whether the lesion has cancer or not by using the NICE classification or one of the newer classifications from Japan, the JANET classification. And if you think there is obvious cancer, You take a targeted biopsy, tattoo the lesion circumferentially, and send the patient to surgery. If you think that is not cancer and you don't think that you should be resecting, take one biopsy from the edge, or if you have a good rapport with your endoscopic resection center, you could defer the biopsy so that as long as the patient gets prompt care, tattoo 3 centimeters distal to the lesion in the same plane and take a photograph. One thing is you should avoid multiple biopsies, jumbo biopsies, snare resection, and tattooing into the lesion. You should avoid all of those. And when you communicate, send a detailed report with color pictures to the EMR/ESD center where they can figure out what's the best way to take care of the patient. At the end of the day, it's not about what technique we use. What matters is whether the patient can be taken care promptly, safely, effectively, and also not making it a burden on their purse. Regarding the resources, if you want to learn EMR, I've posted about 300 videos, and that might be helpful for you. And this is where we practice in the Lee Clark Clinic on the 5th floor. And Lee Clark was the first president of the MD Anderson Cancer Center, a great surgeon with a vision that made MD Anderson Cancer Center what it is today. I bring you best wishes, and I'm very sorry that I couldn't be there. Thank you.